Welcome to the Health Momentum, where we explore how medicine is evolving and why it matters for physicians and clinic leaders. I'm Kenneth Livingston, and today we're really diving deep into a topic that's gaining more traction than ever before: medical tourism and, crucially, its hidden consequences. It's a fascinating area because on one hand, you have patients seeking care, often with excellent outcomes from procedures abroad. But on the flip side, clinics right here at home are often left inheriting a significant burden. And that burden isn't just a minor administrative annoyance, it's a full-blown leadership challenge that demands our attention.
That's exactly right, Kenneth. Medical tourism isn't some niche, isolated phenomenon anymore. It's a reality that clinics truly cannot afford to ignore. And what you said about leadership, it resonates so deeply with me. It's about being proactive, not reactive. We see patients coming back, and sometimes their care is fantastic, but the paperwork, the records, it's a whole different story. This is where leadership comes in, where we need to anticipate these challenges rather than just react to them after the fact.
You know, Daniel, when we talk about hidden consequences, what are the most common issues you're seeing on the ground? Because it's easy to say incomplete documentation, but what does that actually look like for a physician trying to provide follow-up care?
Oh, it's a minefield, honestly. Incomplete documentation is a huge one. Imagine a patient returning needing follow-up care, and all you have is a discharge summary that's barely a paragraph long, or worse, in a different language, or lacking crucial details like implant specifics, exact surgical techniques used, or even drug dosages. Then there are the coding mismatches. Procedures done abroad might not align with our CPT codes, making it a nightmare for billing and reimbursement. And don't even get me started on the billing challenges that stem from all of this. It's not just an administrative hiccup. It directly impacts patient safety, continuity of care, and the financial stability of our clinics.
So it's not just a matter of someone having to spend an extra hour on paperwork, it's fundamentally about risk. Financial risk for the clinic, compliance risk, and most importantly, clinical risk for the patient if we don't have the full picture of their treatment history.
Precisely, and that clinical risk is paramount. If I don't know the exact material of a joint replacement or the specifics of a cardiac stent, how can I safely manage future complications or even recommend the right follow-up tests? It puts physicians in a really tough spot. We want to help our patients, but we're operating with blind spots. And that's simply not good enough, for us or for them.
It sounds like a tightrope walk. You have to maintain high standards of care, but you're often doing it with one hand tied behind your back due to these information gaps. So what can physicians actually do about this? Because it seems like the problem is coming to them, regardless of their wishes.
You're absolutely right. The problem is arriving at our doorstep, so we have to be prepared. My first recommendation is for clinics to standardize their documentation review process for patients returning from abroad. Don't just file it away. Have a dedicated protocol. This means verifying procedural details with the patient, even if it requires extra time, and separating the clinical care assessment from any financial assumptions. We have to treat every piece of incoming information with a critical eye.
That's a strong point about separating clinical care from financial assumptions, because I imagine there's a temptation to just push it through for billing, but that could overlook a major clinical red flag, couldn't it?
Absolutely. If you start making assumptions for billing, you might gloss over a missing lab result or a medication not listed, which could be critical for patient safety. It requires discipline. We also need to leverage technology more effectively. I believe artificial intelligence, for example, can be incredibly helpful here. Imagine an AI system flagging gaps in documentation or normalizing records from different formats or even different languages into something that's more digestible for our systems. It won't replace human judgment, but it can certainly act as a powerful first line of defense, a safety net.
That's a really compelling vision for how technology can augment human expertise, not to replace the physician, but to empower them with better, clearer information from the outset. So, beyond technology and standardization, what about the human element, the dialogue amongst physicians that you mentioned?
Oh, that's non-negotiable, Kenneth. Open dialogue among physicians is essential. We need to be sharing our experiences, what worked, what didn't work, what specific issues we're encountering. This isn't just about complaining, it's about collaboratively creating better systems. We need to ask ourselves, are there common gaps we're seeing? Can we advocate for better international standards for record keeping? Can we build a network of trust where we can get information vetted or translated? This collective intelligence, this shared leadership, is how we reduce risks and improve outcomes for everyone involved.
It's interesting because it touches on something almost philosophical about modern medicine. It's no longer confined by borders. Care is globalizing whether we like it or not. And this brings us back to the fundamental question I posed at the top of the show. Who should ultimately carry responsibility when these systems fail to connect? Is it the patient who made a choice to seek care abroad? Is it the provider abroad who delivered the initial treatment but maybe didn't adhere to domestic documentation standards? Or is it the clinic delivering follow-up care at home who now has to manage this complex situation?
It's a really complex question, Kenneth, and there's no easy answer. I think it's a shared responsibility, but the clinic delivering follow-up care at home has a unique burden. They are the ones who ultimately bear the immediate risk for the patient's well-being and the financial and compliance burden. That's why being proactive, establishing robust internal protocols, and fostering that physician dialogue is so critical. We can't simply point fingers. We have to build resilience and robust systems within our own organizations, while also advocating for broader changes and better communication across international healthcare systems. It's a collective challenge that requires individual and systemic solutions.
That's a very pragmatic and forward-thinking perspective, Daniel. It's about owning what you can control and collaborating on what you can influence. It truly is a leadership issue, as you say, and anticipating these second-order effects is key to protecting patients and managing those significant financial and compliance risks. Dr. Daniel Cham, thank you so much for sharing your insights today. It's been incredibly illuminating.
My pleasure, Kenneth. It's a conversation we absolutely need to be having more often.
And for our listeners, if you're interested in continuing this conversation, Dr. Cham welcomes you to connect with him on LinkedIn. You can find him at linkedin.com.and-daniel-cham.md-6690-36285. Together, as he says, we can navigate this evolving healthcare landscape responsibly and strategically. Thank you for joining us on the Health Momentum. We'll catch you next time.